or educational, environmental, and policy approaches to primary prevention. And when we're talking about educational interventions, what we're talking about is assisting people in making choices among what is already available to them, among the options that are already exist for them. And so examples of primarily educational approaches in my country include a program called the Diabetes Prevention Program you may have heard of. Other projects, there was a project called Project Challenge, which was a home visiting program, teaching people healthier cooking approaches, teaching sort of holistic approaches to stress reduction, healthier diet, physical activity, and SNAP Ed, which is something that you'll hear about in the next speaker, Dr. Trude. And there are many, many others of primarily educational approaches to addressing chronic disease prevention. What are some of the key things that we've learned from this work in the past? Really that knowledge-only education is ineffective. We need to build other psychosocial aspects in relation to knowledge, self-efficacy, awareness, skills, and many other factors. We need to do a lot of formative work and community engagement work to determine what to promote, what's salient, and how to promote it, what concerns are salient and important to people, how to communicate to people, who should be the communicators. This is all fits within the heading of how to better deliver education. And we need to think about reinforcement using multiple media. Another thing that we've learned in a lot of the educational work that we've done over the years is the importance of providing social support in the work that we do. But educational approaches can only go so far. If you're only affecting the choices that people make from what's available to them, you're ignoring a whole other aspect of the issue. And that's why I think it's important to consider working at the level of environmental approaches. In contrast to educational approaches, environmental approaches change what is available to people, change the factors or the choices that they have available to them. So I want to talk in some detail about what I mean by changing the food environment by improving access. Access includes changing availability. It includes changing the price of potentially of different foods. It could work to change or affect the ease of obtaining food in terms of how you get to this food venue for that food, the location of that food, or signage or marketing to find those foods within that store. And we can talk about this work taking place at different levels. One could include at the neighborhood or community level. For example, building or putting in new supermarkets. There's been a lot of effort to increase access to healthier foods by encouraging through financial incentives and other means, putting in supermarkets, developing farmers markets, improving transportation. And in my city of Baltimore and many other cities in the US, there's an effort to introduce urban farms, small farms within the city. We can also think about changing access to foods within existing retail food stores and prepared food sources. This could include decreasing the availability of unhealthy foods or increasing the availability of healthier foods. You could talk about changing the physical location of foods within these small stores and other forms of nudging. We can think about renovation of stores, so adding fruit and vegetable or produce displays, or perhaps in terms of manipulating price. This takes us to the possibility of policy approaches. So while educational interventions are about changing what people choose among what's available to them, and environmental interventions are about changing the available options, so changing access, policy approaches can be supportive of both educational and environmental interventions. And this is just a long list of some of the policy approaches that have been tested at both the city and federal levels in the United States to improve the food environment. So this includes supportive of both changes to the supplemental environmental nutrition program for women, infants, and children, different types of taxing, requiring small stores to stock a broader array or depth of stock of healthier foods, and many, many other approaches have been tried at different levels as policy approaches to improve the food environment. My understanding so far, though, from all of this work is there really is no silver bullet. There really is no single solution from this menu that works. You need to think about combining different solutions. You need to think about not trying to throw everything into this mix, but figuring out the most parsimonious, effective, multi-level approaches that combine education, environmental change, and policy to support it. And it is also true that the best combination of these things will differ from setting to setting, from city to city, from rural area to rural area. So I want to turn now to the work that we've been doing for the past 20 or so years in trying to combine educational, environmental, and policy approaches. And I'm going to start off with the work that we've been doing in Baltimore in urban settings. And this is a food desert map of Baltimore City. Baltimore City is a city very near Washington, D.C. on the east coast of the United States with a population of about 600,000 or 650,000 people. I know that Dr. Trude is going to give you a lot more in-depth description of what it's like inside the city. So I'm just going to say that I just want to point out in this particular map, the pink areas represent healthy food priority areas. These are food deserts. These are areas which do not have ready access to a supermarket. And there's typically a very high proportion of the population is low income. If you were to visit these pink areas, these healthy food priority areas, you'd see that that the system of food or food access in that city could be described as taking place at different levels, from the producer all the way down to the individual level. But if you look at the city as a whole, you can see there's actually about 633 small grocery stores or corner stores, 80 chain convenience stores, 47 supermarkets, 6 public markets, 24 urban farms, 225 food pantries. There's nearly 24 wholesalers. There are a growing number of dollar stores, which is interesting, and pharmacies that sell food. Public schools have food school meal programs. Recreation centers have after-school feeding programs. There's food assistance. There's local farms and farmers markets. So it's actually a really complex food system with many different pieces. And a key issue is, where do we choose to work if we're going to try to change the food environment? What I want to point out to you is the fact that the corner store is ubiquitous in Baltimore City, especially in the low income areas of the city. This is what a typical corner store looks like. And our initial approach was to really begin thinking about working in existing food sources. Hundreds of small food sources exist. As you saw, there are over 600 corner stores in Baltimore City. They're already operating at the lowest income areas of the city. They're open 5 to 7 days a week, 12 hours a day, and they're generally visited all the time already by community members. So in some respects, they make a better choice of where to visit and to where to work in terms of trying to change the food environment for disadvantaged populations in the city. We've done a number of studies over the years to address corner stores and to address the food environment in Baltimore. I'm going to talk about this first example, Baltimore Healthy Stores. I'm also going to talk about the second example, Baltimore Healthy Carryouts. And then Dr. Trude is actually going to present a lot of detail on the Be More Healthy Communities for Kids, which was the focus of a large part of her research. So the first, I'm going to talk about Baltimore Healthy Stores. This was a pilot project that worked with corner stores in East and West Baltimore. And we assessed a consumer sample pre and post from both areas. And the intervention took 2 main approaches. One was to increase availability of healthier foods, to increase the stocking of healthier foods, 1 to 3 new foods per phase. There were 5 phases. And we provided incentives, including an incentive card to their gifts, to their wholesaler, stocking guidelines and promotional materials to promote those foods. We provided visual materials to promote the healthier options in the stores. And we were quite pleased to see that in terms of both stocking and in terms of sales of healthier foods, we saw that the intervention stores significantly increased the range of healthier foods they stocked and the sales of those healthier foods that they stocked in comparison to the comparison stores. And in fact, that this increase in stocking and sales of healthier foods was maintained for both 6 months after intervention, both in terms of stocking and sales. So that was really very reassuring initial results from that work. We also looked at our consumer sample, and we saw that after adjustment, we saw statistically significant impacts on consumer food preparation methods and on frequency of purchase of promoted foods, and a trend for healthy food intentions, which was a psychosocial measure we were assessing. So this was all very reassuring. But I will say in Baltimore City, in fact, quite a large proportion of the food consumed at households come from prepared food sources. And this leads me into the follow-up study that we did in the city, which was called Baltimore Healthy Carryout, so essentially small restaurants. In the United States, in the last 3 or 4 decades, there's been a tremendous increase in the amount of dollars and the proportion of food dollars spent on foods consumed or purchased away from home. And on average, American adults consume prepared food meals about 3 times a week. And these meals typically contain more calories, saturated fat, sugar, sodium, lower in fresh fruits and vegetables, dietary fiber, and so forth. And the frequent consumption of prepared foods has been associated with poor diet quality, increased BMI, and weight gain. And so we implemented an intervention in 8 carryout restaurants in Baltimore City. The intervention included 3 main strategies: redesign the menu, promoting healthy sides and beverages, and creating a healthy combination meal that could be sold for an affordable price. This gives you an idea of one of the participating carryouts and what some of the signage looked like that was added to their carryout restaurant. And here are some of the results. So the purple bar represents change in percent of sales in our intervention carryouts, and the orange bar represents change from baseline in healthy food sales from our comparison carryouts. And what you see is kind of a stepped effect with each increase in dose or each added phase of the intervention, an increase in the percentage of food items that compared to baseline in terms of the sales of the healthier foods. When we looked at the ratio of healthy to less healthy food item sales from baseline, we saw the same effect. Intervention stores as compared to comparison, I should say carryout restaurants, were increased relative to baseline, the proportion of sales of healthy to less healthy foods. And this particular image showed the change in the revenue for intervention versus comparison stores. And we saw that the intervention stores actually increased their gross revenues by about 20 to 25% over the course of the intervention. And I was really pleased to see that this program was adopted by the city of Baltimore and expanded to the Baltimore's city markets. So we have 7 or 8 public markets in Baltimore City. So if we look at this whole body of work, and this includes all of the studies that were on that little flowchart diagram that I presented earlier, what have been the impacts of this work in Baltimore? And just sort of in summary, just some summary impacts. At the wholesale level, we've seen increased stocking and sales of healthy foods and beverages. In corner stores and carryouts, we've seen increased stocking and sales of healthier foods and beverages, as well as of WIC foods, so foods that are part of the Federal Food Assistance Program for women, infants, and children. And in consumers, we've seen increased purchasing of these foods and in their consumption by community members. And in some cases where we've done these measures, we've seen positive health effects, including a reduced BMI. What's our ongoing work in the urban setting? In the urban setting, we've actually focused our work more recently on improving healthy food distribution. And this is because what we find is that there's a completely different form of distribution to these small stores if it's a bag of potato chips, an unhealthy food, versus if it's a bag of fresh produce, a healthier food. If it's an unhealthy food, there is a strong supply, a strong perceived demand. The food is delivered to the corner stores. It's often heavily incentivized with free freezers, refrigerators, display racks, reduced prices. On the other hand, if it's a fresh produce or any other sort of healthy food, the corner store owner actually has to go get it themselves. And there is costly or no delivery and high minimum purchases. And so we're trying to address this problem in Baltimore City through developing an app, which we call the Baltimore Urban Food Distribution App, or BUD, which is a mobile application to improve healthy food access in Baltimore City. And the goal of this work is to develop an affordable solution to corner stores for them to receive healthier foods in a cost-effective way. This gives you some, we're in the process of developing this app right now. This is what the screenshots of what the app look like. It will work in Spanish, English, Korean, and Mandarin. And basically, you are able to look up products on the store, on the app, different foods. We're able to add new products. So if you are a local producer, like a farmer, you are able to add products to the app, or a wholesaler, you can add products to the app. And you're able to set what we call buddy up deals. So buddy up deals is essentially collective purchasing, like Groupon, where you're able to say if you can get enough people together to purchase, let's say 100 pounds of the items, we will give you a reduced cost. So collective purchasing. And then also, once a delivery mechanism has been selected, there's the possibility of shared delivery to further reduce the cost. And this is all about making the distribution of healthier foods more affordable in these low income areas that are mainly, the main retail food source is small stores, corner stores. I want to turn my attention now briefly at the end here for the work that we've been doing in rural settings. So in rural Native American communities, these are very remote. There is frankly no or very little public transportation. It's also typically food deserts or healthy food priority areas. And there is a strong valuation of traditional foods. And we've been working in Native communities for over 20 years, a series of projects. Each of these have been written about in some detail. I'm going to talk just about Native Navajo Healthy Stores and a project called Prevent 2. And Navajo Healthy Stores had as its goal to reduce risk for obesity and chronic disease by increasing availability, purchase, and consumption of healthy foods on the Navajo Nation, and to make it self-sustained. And we made it sustained by working with the Navajo Special Diabetes Program, funded by the Indian Health Services in Native American communities. And we provided training materials and evaluation to the people who implemented the program, who were all Navajo community members. We worked with local stores to increase availability by encouraging them to stock 3 to 4 healthy foods and beverages per phase. We did shelf labeling, we did interactive sessions, and these are some examples of some of the educational materials that were developed. And this presents some of the results of this project. Basically, we saw a significant impact among those people who are more exposed to the intervention in terms of improvement in food intentions, healthy cooking scores, healthy food getting scores. And finally, we saw a reduction in BMI associated with those people who were very, very exposed, or community members who were very exposed to the intervention. So that was a positive effect. We followed up on this work with a project we called Prevent 2. This project was recently completed and took place in 4 Native American communities in New Mexico. These are them listed here, and in 2 Native American communities in Wisconsin, depicted here. And the intervention had 5 different intervention components: a store component, a school component, a community media component, a worksite component, and a policy component. And this just gives you some idea of what the curriculum looked like. It was developed for children in grades 2, 3, 4, 5, and 6, and the child was encouraged to act as a change agent. I'd also want to emphasize the physical activity piece, which ran through all of the different components of the intervention, included a pedometer challenge that was introduced at work sites, and it was supported by many other components. So this is an example of what we call a multi-level, multi-component intervention. You're not just working in schools, you're not just working in food stores, you're not just working in work sites, you're working in multiple locations. And the idea is that you can reach more different kinds of people in the community. These are some of the results. We saw a significant decrease in diastolic blood pressure, especially among those people who were most exposed to the intervention. We saw a improvement in healthy eating index, again, especially among those people who are most exposed to the intervention. We saw an increase in walking, again, among those people who were either in the intervention communities or most exposed to the intervention. So I want to summarize now with a few key points about this work that we've been doing. So first of all, I want to say that the food environment interventions can be effective for addressing key risk behaviors for chronic disease in disadvantaged communities. MLMC stands for multi-level, multi-component. These kinds of multi-level, multi-component interventions, like you saw for O-Prevent 2, like you'll hear about from Dr. Trude in the next presentation, have been successful in improving access and consumption of healthy foods and in reducing obesity in some cases. But I think it's really important to remember this advice to combine educational, environmental, and policy approaches when possible. And a key thing that we've learned is that community engagement is hugely important, and this has to take place at multiple levels. Moving forward, we are in the process of preparing a new grant to fund the next stage of our work in Native American communities, which includes simulation modeling as one of the approaches that we take. If you're interested in visiting our website, all materials for our interventions are available at this website, www.healthyfoodsystems.net. We work with a large team of collaborators on these projects in Baltimore and in indigenous Native American communities. This is just a sample of the current collaborators. Dr. Trude was one of the, certainly should be pictured up here as one of the collaborators of this work. I want to thank you for your time and attention today. This is all the different ways that you can get in touch with me. And we really appreciate, I really appreciate hearing any comments or questions that you might have. Thank you.
Thank you, Dr. Gittelsohn. Já temos perguntas muito interessantes, mas para a gente não atrasar as próximas falas,
questions, but in order not to delay the
a gente
next
conversar com elas ao final, para a gente ter contribuição dos demais pesquisadores da mesa.
To her and then have the contributions
Obrigada pela
from all
grande
members of the panel. Thank you for
trazer a
your
experiência do seu
contribution,
trabalho com um
bringing
approach
the experience of your
multicomponente,
work,
multinível, combina as
multi-component,
dimensões da educação, da
combining
tecnologia
dimensions
com
from
aplicativos para
technology
facilitar
through
acesso,
the app,
ambiente político. Traz pontos muito importantes, incluindo para a
all
realidade da
very
América
important
Latina,
topics,
uma
especially
forma
for the
de
Latin American
populações
reality.
vulneráveis. Como muito bem dito,
And
there is no
as
silver
you
bullet.
said, there is no silver bullet.
Você trouxe muito
So
bem a necessidade de ações
you
integradas que
showed
agem
the
em
importance
diferentes
of
dimensões.
integrated
Para a gente
actions
dar
at different levels.
continuidade, agora eu gostaria de
Let's now
cumprimentar e
continue.
convidar para
I'd like
ministrar a
to
palestra
invite
a doutora Ângela
as the
Cristina
next speaker,
Bisotto,
Dr. Angela Cristina.
é brasileira,
Bisotto.
mas reside fora,
She's
como
Brazilian, but
professora
she
da New
lives
York
abroad.
University. Também
And
possui
she's a professor at
experiência em
the New York
intervenções
University. She
comunitárias
has
com comunidades carentes.
experience in
Mais
community interventions
trabalhado com
with needy
pesquisas
communities.
sobre o
She's been
comportamento de
working with
compra de
research
alimentos de famílias
in
que fazem
terms
parte
of
do
purchase
programa de
of food
nacional dos Estados
in
Unidos.
families that are
Neste
part
momento,
of
passo a
this
palavra
program
para a
in the
professora.
US. Now I'd like to give the floor to our professor. Thank you, Mariana. Hello, everyone.
Maryland, where I did most of my intervention work. But I really look forward to discussing at the end of this panel ways to adapt some of those strategies in the Latin American context. So today I'll be exploring strategies to address the disparities related to nutrition and healthier food purchasing behaviors. We see striking differences in rates of obesity across race and ethnicity. In the United States, Black and Hispanic groups have the highest childhood obesity prevalence in the country. And these disparities can be exacerbated based on where we live. Some individuals die 20 years earlier than others who live just a few miles away from them because of differences in education, housing, safety, community, and access to quality health care. For millions of people living in the United States, especially those living in low-income communities of color, finding fresh produce is not easy. Food service, grocery stores, farmers markets, and other vendors that sell fresh fruits, vegetables, and other healthy foods cannot be found in these neighborhoods. But what can be found, and often in great abundance, is our convenience store, fast food restaurants that sell mainly cheap, high-fat, high-sugar processed foods and offer few healthy food options. In a national survey with more than 4,000 low-income families, the most common barrier to healthy eating was associated with living too far from a grocery store or not having access to a reliable transportation to get to a store. Addressing the social determinants of health, which are the determinants and conditions that we are born, grow, and live, can empower the population to live a healthier life. This includes improving conditions and opportunities at multiple levels of the socio-ecological model, from the individual, interpersonal, community, and public policy levels. But today, I will give you a bite-sized view of my work and talk about two different studies that I think capture really well different strategies to support healthy food purchasing at the community food environment and at the policy level. So in this presentation, I'll be exploring the socio-ecological model from the perspective of changes in dietary patterns related to influence from the food environment and exploring promising strategies to improve food purchasing behavior and prevent overweight and obesity. I would then argue that voices of families, communities, and organizations is critical to the success of policies and interventions that ensure an equitable access to healthier foods. Food environments have become an important topic in debates to combat obesity. Dr. Gittelsohn just showed you the Baltimore food map. The areas marked in orange are the low-resource communities that lack access to grocery stores, also known as food deserts. We can also see that these areas have disproportionately higher prevalence of small food stores represented by the purple dots. If you zoom in those areas, you will see an abundance of small food stores that sell primarily high-energy dense snacks, sugary beverages, and fried foods. Corner stores are hardly present in lives of children growing up in urban communities in the United States, especially in Baltimore. On average, a typical Baltimore adolescent will purchase a snack at a corner store 3 times a week. They might stop by at a corner store before going to the school, or they will purchase candies and sugary beverages on their way to a recreation center before returning home for the day. So this demonstrates all the different settings that are influencing a child food purchasing and consumption behavior every single day. So the first study I'll present today is the Be More Healthy Communities for Kids project, also known as BHCK, which you have heard a bit in Dr. Gittelsohn's presentation. I had the pleasure to work with him during my doctoral training to implement and evaluate the impact of this intervention that aimed to change the community food environment around schools. Recognizing that policies, neighborhood resources, marketing, our individuals' food preferences all influence how we shop and eat food, multi-level frameworks are being recommended in order to better generate solutions to improve health and address the complex issue of obesity. I will now walk you through an intervention that sought to improve the out-of-school food environment in underserved communities of Baltimore with integrated strategies implemented across multiple levels of the food system. Dr. Gittelsohn just presented on this work and show you how we improved supply of healthier foods by working with wholesalers, corner stores, and carry-out restaurants. And I will focus now on the different strategies we implemented to improve demand for healthier foods. And we did that by working with 30 after-school programs in the city. Recreation centers are after-school programs usually located in a building next to a middle school. Baltimore has a total of 40 recreation centers, and you can find an average of 5 corner stores around each center. Children do their homework and have supervised physical activities and games, and they receive an afternoon snack and sometimes a dinner. Nutrition education is not part of their curricula. For this component of the intervention, we train community high school students to deliver nutrition education to children attending the after-school programs in Baltimore. The goal of this component was to build knowledge and self-efficacy for healthy eating and to further improve demand for healthier foods in the small food stores, such as corner stores and carry-out restaurants. We implemented a social support approach. Based on observational learning principles, we involved peers in the delivery of the intervention, as peers have the potential to serve as role models for behavior change. In our project, peers were known as youth leaders. We trained 30 youth leaders who were local college and high school students between 18 and 22 years old to deliver the nutrition intervention to children attending the recreation centers. Youth leaders received more than 12-session training program, which included team building activities, development of the youth leader skills, and opportunities to practice the intervention nutrition education curriculum. Youth leaders were a very important part of this multi-level intervention, as they were the face of the program and appear in all communication materials, such as handouts and posters put up at corner stores and carry-out restaurants. They served as spokesperson in our social media platforms, and they also went to stores around each recreation center to do taste tests and point of purchasing promotion of the BHCK promoted food items. Youth leaders' primary role was to lead nutrition education with children in the intervention recreation centers. Sessions in the after-school programs started with a brief introduction to a nutrition topic, followed by games, activities, and cooking sessions to reinforce the messages and provide opportunities for observational learning. And we finalized with a taste test of a healthier food being promoted across all the other BHCK components. And lastly, all children received a giveaway that was related to the topic or food being promoted. For example, when we promoted water as the best way to hydrate, all kids received a water bottle with the project logo in it, like in this photo. We also use social media to integrate the intervention across multiple levels. We had Facebook, Instagram pages, and a texting program that reinforced the intervention messages and featured each intervention component through daily posts. So recognizing that multiple factors across the social-ecological model influence our diet intake, we aim to evaluate the impact of a multi-level childhood obesity prevention intervention on diet among low-income Black adolescents. We hypothesize that the strategies aim to improve both supply and demand for healthier foods implemented across multiple levels of the food systems would improve purchasing and diet among children. So this was a group randomized control trial implemented in underserved communities of Baltimore City. Study randomization occurred at the neighborhood level, with recreation centers being the nucleus of each neighborhood. And they were eligible to be in the intervention if they were located in a low-income, primarily Black community with low access to healthy foods. 30 neighborhoods were eligible and randomized into intervention in red and control in green. We assessed diet intake among children using the Black Kids Food Frequency Questionnaire at baseline and follow-up. The intervention was implemented across 6 to 8 months, and we promoted primarily low-fat, low-sugar snacks and beverages. And among caregivers, we assessed diet intake using the National Cancer Institute Fruit and Vegetable Screener to assess fruit and vegetable intake, also at baseline and follow-up. I will now show you the results of the multi-level analysis on purchase and diet among adolescents. We saw a positive impact of the intervention on adolescents' purchasing habits, as adolescents in the intervention communities bought more varieties of healthier foods over time than children in the control communities. And older children living in the intervention communities decreased intake of kilocalories from sweet snacks by 3.5%. A decrease in 3.5% of kilocalories from sweet snacks can be translated into 2 fewer Starbursts, the candy, or 2 fewer Oreo cookies per week. This is important given that sweet snacks are among the most frequently purchased items by adolescents in corner stores. So let's think about what this could mean at the population level. This is a graph that shows the Healthy Eating Index, which is a proxy of diet quality across the lifespan of Americans. The diet quality is assessed by the Healthy Eating Index that ranges from 0 to 100, which shows the percentage of adherence to the dietary guidelines for Americans. We know that adolescents have the lowest diet quality in the country, and that sweet snacks like cookies and candies are really high in added sugars, which contribute to a lower healthy eating index. Therefore, multi-level efforts to improve community food environment can increase both the supply and demand for healthier foods and potentially shift the average total healthy eating index score among adolescents by 2 points. Although BHCK was targeted at children, we also hypothesized that caregivers would have improved food-related behaviors as they were also exposed to some of the components of the intervention, especially social media. We did not find an impact on food purchasing among adults, but we did find a marginal impact of the intervention on consumption of fruit per day. We also examined the correlation between being exposed to the intervention and consumption. We could see that caregivers more exposed to social media, meaning that they follow our Instagram and Facebook pages, or they saw more posts, they were more likely to have greater fruit intake than those who had a low exposure to the intervention. So in summary, improving the community food environment along with nutrition education was effective to improve diet among children. Nutrition education is important, but not enough to change complex behaviors. So just knowing what and how to eat doesn't necessarily translate into behavior change. We need to create a supportive environment that promotes healthier food options so consumers can make informed decisions about what to purchase. Thinking that interventions to improve both supply and demand for healthier foods are complementary and should be implemented in synergy. Peer social support is a promising approach to deliver nutrition education to children in food environment interventions. The second study I will present today is my ongoing work aiming to identify solutions and inform policies to promote healthy eating among low-income families in the online food environment. We know that individuals consume over 60% of the daily calories at home, and that foods and beverages from grocery stores account for the vast majority of at-home purchases. And online grocery shopping has become an important part of our food system, especially during the pandemic. Online grocery shopping is a growing service that potentially addresses barriers imposed by food deserts by bringing foods to families. However, other barriers remain for low-income families. For example, many stores require the use of a credit card in online purchases, and the additional cost of delivery is significant for those shopping on a budget, thus widening the gap of healthy food access. The Supplemental Nutrition Assistance Program, also known as SNAP, provides nutrition benefits to supplement the food budget of families in need so they can purchase healthy foods and move towards self-sufficiency. The SNAP program is somewhat similar to Bolsa Família in Brazil in some ways, as it's a government welfare program based on income eligibility. But unlike Bolsa Família, SNAP can only be used towards grocery foods and beverages. SNAP participants received a debit card known as EBT, like this, where their benefits are loaded each month. They can only use this card at authorized retailers. SNAP also has an educational component. So each state has a SNAP ad, which is the nutrition education component that teaches people how to shop and cook healthy meals. In order to provide low-income families with more equal opportunities to access healthier foods, the USDA, United States Department of Agriculture, is now partnering with some retailers to allow the use of the SNAP benefits for online grocery purchase. The policy requires that retailers only allow SNAP benefits to be used towards eligible groceries, and that's not used towards fees and other costs associated with online services. The USDA online grocery pilot initially included 8 states and about 3 retailers in each. In Maryland, Amazon, Walmart, and ShopRite were the participants in the pilot. In response to the COVID-19 pandemic, the pilot program expanded rapidly to additional 48 states and more retailers across the country. I just want to briefly show you how SNAP works for online purchase, taking Amazon as an example. So after adding a valid SNAP EBT card number into an Amazon account, the consumer will find products that are eligible for purchase with SNAP, labeled as SNAP EBT eligible. And in the shopping cart, customers see how much of their purchase is SNAP eligible and how much to unlock for free delivery. So for Amazon only, delivery is free on orders of $35 or more, but the delivery policy changes by retailers. So last year, we received funding from the Robert Wood Johnson Foundation to examine barriers and perceptions of SNAP families towards online grocery shopping. The project is based on the theory of planned behavior to explain SNAP families' utilization of online grocery shopping. We are also assessing multiple factors that influence online shopping decisions at the online food environment, such as marketing, food selection, delivery, and payment. We assessed 310 low-income families with young children who are either receiving SNAP or eligible but not enrolled in the program. Data for this mixed method study was collected between November 2020 and March 21 via online surveys and interviews across the state of Maryland. Majority of the main grocery purchasers were female, between 30 to 39 years old, and reported receiving SNAP in the past 12 months. At the time of the study, there were 10 grocery chains providing online service in Maryland, as mapped here. 85% of the participants in our study lived in an urban area. 67% reported having home delivery services of grocery available to them, and a higher percentage, 85, reported having an option to pick up groceries at their store or curbside. So we are finding that majority of low-income families in Maryland are actually using online grocery shopping. And among the 81% SNAP recipients, most have used their SNAP benefits to shop for groceries online. Among participants who reported ever shopping for groceries online, 45% said they purchased most or all groceries online. And the majority perceive spending the same amount or less online than in-store. So families are buying groceries online because it saves time, it's convenient, and easier to know what they need to buy when they are home. So this is a quote from a parent we interviewed. She said, "It appeals to me because the kids, the corona, taking kids to the store, walking up and down the aisles, I forget stuff when in the store. If I am in the house, I know what I need. I can just click and order." However, families don't trust others selecting their products. They are concerned about the quality of the foods being selected and think it's more expensive to buy groceries online, whether it's because of the fees involved or the inability to use some of the coupons or take advantage of the in-store sales. Here's the quote that illustrates this issue. "The shoppers are taking the groceries in the front that nobody wants, and then the stores mark the price down after shoppers bring my groceries to me. So I still have to pay the full price when it would have been cheaper a few minutes later." We are also
Dr.
asking
Trude,
families. Yes.
Just to let you know that you have 5 minutes left.
Okay, thank you. We're also asking families to share their itemized receipt from an online grocery purchase. Here are some examples of what and where they're shopping and how much they're spending. As a first preliminary analysis, we could find a lot of packaged food items. Fresh fruits and vegetables were rarely seen, sometimes a lettuce or a tomato. So in summary, the SNAP online program may change how we define food deserts, facilitating grocery shopping for those who live far from grocery stores, do not own a vehicle, or have young children. However, additional barriers need to be addressed to promote equitable access to healthier foods, such as waiving delivery fees, improving delivery windows, or expanding to other payment options, such as allowing cash. There might be some unintended consequences of the program, with a potential increase in purchase of foods that are high in sugar and fat and fewer healthier choices online. So revisions in the current policy paired with educational programming delivered by SNAP Ed may be needed to ensure that SNAP families can support and have online healthy eating purchases and eating practices. We learned from our work that low-income consumers are not buying fresh produce online because of cost and food selection concerns. So I will build on the findings from this formative work to leverage existing food and nutrition policy programs to address disparities in diet quality among diverse populations. For example, I want to explore whether applying behavior economic strategies such as nudging in the online environment would support healthy food decisions. Many participants mentioned they don't trust others selecting their foods. So it's important to address this barrier and ensure that higher online shoppers are trained to improve trust and purchase of fruits and vegetables. And third, I would like to test pricing strategies such as applying discounts on fruits and vegetables and increased prices of unhealthy foods for online purchases as a way to improve quality of foods selected. I'm looking for collaborators in Latin America, especially Brazil, so we can together test innovative strategies to improve healthy food purchasing and consumption among low-income communities. More specifically, how can we help Bolsa Familia beneficiaries to purchase fresh, nutritious, and affordable foods to improve food and nutrition security? Would promotional materials and nudges in grocery stores help? What about testing strategies with online grocery stores? How can we translate what we learn with interventions, studies, and apply in other contexts, such as Latin America? So I'm currently partnering with researchers in Kentucky and North Carolina on an intervention funded by Share Our Strength. We are testing whether helping low-income shoppers setting up their online grocery cart with healthier items improves quality of food purchase and food security. We have just finished the intervention and are collecting follow-up data, and I'm looking forward to sharing what we find with you. So in summary, are we done? I can just finish. Yeah, I just want to acknowledge all my colleagues and collaborators, and I'm looking forward to building new collaborations across Latin America. I'll be happy to take any questions, and feel free to reach out to me on my email below. Thank you so much.
Thank you so much, Dr. Trude. Obrigada por compartilhar esses estudos com estratégias diferentes.
Thank you for sharing your work in the community environment with such an interesting, robust technology with different actions, taking into account synergy with public policies in such detail.
For us to continue now, I would like to salute and invite Dr. Teresa Shamah, who is a nutritionist and is the director of the Center for Research and Evaluation and Studies of the National Public Health Institute of Mexico. She was the coordinator of an important national survey on new health and nutrition in Mexico, and today she'll be able to share with us her experience with the assessment and intervention in school food environments in Mexico. So now I'll turn the floor over to the researcher, Teresa Shamah.
Thank you. Thank you very much for the invitation. It is really very interesting to be here to share with you the Mexican experience. I'm very happy to be here, this interesting panel on food environment interventions. I would like to share with you today what we're doing in Mexico, not focusing on specific studies, but rather from a public policy perspective in the change of food environments in my country. We have a long way to go, but I will briefly share all of the progress made. We will talk about the nutrition status of school children in Mexico. This is an ongoing permanent initiative in Mexico, which have been the factors that have promoted obesity in school settings, which are the previous government initiatives that have been implemented. The new administration just started and in 1918, and with the onset of the pandemic, I will share progress made and initiatives to change school settings and recommendations that have been implemented. Let me start with a quick overview of the nutrition state of the Mexican population with our health and nutrition surveys. These surveys have the acronym NSANUT in Spanish. These surveys are carried out every 6 years, but as of the pandemic in 2020, we will follow these surveys on a yearly basis. And we will keep on doing these researches as enhanced in the United States. So what you see on screen, you see that in 2019 to the current moment, we carried out 5 national surveys of health and nutrition, and the prevalence of overweight and obesity in children from 5 to 11 years of age has increased. And 1 every 4 school-age children are overweight or obese. Per gender, if we consider 2020 with the onset of COVID, you see that there is higher prevalence in males from urban areas compared to males from rural areas, with statistical significant differences in women. If we compare the situation in children between 12 to 19 years of age, we see how obesity has increased in this age group in 2 years, almost 5 percentage points, almost 44% of our teens. And in 2020, we see how the prevalence has increased in male teens in urban sites. Very specific studies to understand the pattern of obesity in Mexico in children from 11 to 19 years of age show that BMI category metabolic index and metabolic syndrome indicators is greater in those with obesity. We see that obese children have higher glucose indicators, triglyceride, insulin, and HDL. If we consider food consumption of school-age children at national levels, consider the blue columns, which show school-age children intake. And look at the low intake of beans. In Mexico, beans are very much consumed. And look at the low consumption of beans, and produce is very low in the percentage. At the extreme of this chart, we see that there are discretional calories that contribute to 25 to 30% of daily diets, which should be decreased by 300%, where we include sugar, beverages, and sweet snacks, fried snacks, and junk food. We tried to analyze the per capita intake of sugar derived from food, or which is called intrinsic sugar, or sugar added to food or beverages, how much sugar children add. And in green, you see the intrinsic sugar of food, and these are the calories in daily intake to the diet. But we see that children add twice as much in blue. So in children from 1 to 4 years of age, all the way up to teenagers, the contribution of sugar to diet is more than 300 calories, and with teenagers, more than 400 calories. So Mexican children consume large amounts of added sugars in their diets, which is putting their health at risk. If we remember WHO recommendations of less than 10% of total energy of sugar added to the diet, and if we want to have additional benefits, should be less than 5%, we see that 58%, which is school-age children, and up to 85% of teens, intakes more than 10% of their total energy from added sugars. And I also would like to mention that sweet beverages are the main source of additional sugars in diet, 70.3%. Which are the promoting factors of obesity in the school setting? Well, in Mexico, public schools have classes during 4 to 5 hours daily. Most of our children have breakfast at home. 25% of children have breakfast in school, having already had breakfast at school, and their main meal is at home. So the desirable diet at school should be a very light snack at school. So there are 5 chances to eat during 5 hours. So during a 4 to 5 hour period, they can snack 5 times. And there is high availability of foods and beverages with high sugar and fat content, high calorie intake, soft drinks, juices, and we have very limited availability of fresh fruit. And as you can see in the pictures, these are the canteens, school bars that function within schools. So what about energy consumption in school? Well, it is around 550 kilocalories per capita. That is 35% of the daily intake recommended. And during breaks, they intake 433 kilocalories, 75% of the recommended intake. Another factor that has influence on obesity and overweight is the limited periods allotted to physical exercise, which is an average of 12 minutes per day. Physical education is not included in curricula. There are very limited resources for physical activities, and it is forbidden to run during breaks. And breaks mean eating snacks. 1 out of every 3 schools has fresh water available in their yards. And there are 90 children per these drinking devices. Some schools have water dispensers in common areas, and 12% of these dispensers were not functioning during the observation. Another study in the random sample of 60 primary schools in Cuernavaca and Guadalajara, in a 60-meter diameter with georeference, we see the stores or sites where children could, outside of the school setting, purchase industrialized food and have access to ads. In these 60 meters environment, we found 6 stores, neighborhood stores in a 100-meter diameter. Food ads in this area was amazing, regardless from the fact that schools are public or private. 50%, that is 1 every other 2 schools, had ads of sweetened beverages and of snacks, sweets, dairy products with chocolate or sugar added, very little water available, and public schools have 5.6 average of ads, and ads in private schools is 2.4. So what actions have we implemented as of 2018 to change the school setting? Guidelines include legislation for the sale and distribution within schools. The baseline sample shows high availability of these foods. And in stage 3 of guidelines for 2014, 56% of fried products and snacks, as these breads and Danish and typical foods were offered. And we saw that only 3.1% sold regular drinking water, and almost none had fruit and vegetables. Only 70% of products could be rated as healthy, even with the enforcement of the guidelines. Sales of sugared beverages or with artificial sweeteners were sold in school canteens. 1 in every 5 schools sweetened beverages, and more than 80% drank light soda or sugared juices. This chart was borrowed from an NGO called The Power of Consumers, where we have the visual explanation of the guidelines, where sugared beverages are not permitted. From Monday to Thursday, we see produce, natural water, beans, fruit, and on Friday, some with added sugar would be permitted. Soybean beverages or cookies or snacks, just 1 day a week. We have fought against this free day for the free sale of all of these products. What about breakfasts and snacks for school-age children? 87% of children reported that they have breakfast or eat before going to school. 14% were part of school meals program, and out of these 14%, 85% had already had breakfast at home. 66% of the children take snacks from home. 73% take money to buy something in the school canteens, and 41% of the children take snacks and food and money, both things, and 20% include in their snacks vegetables, and only 28 fruit more than 3 days a week. 50% of children include a sweetened beverage in their home snack. What about physical education? Children reported in the reports that they had 15 minutes or less of physical activities. 1 of every 5 children from 16 to 30 minutes, and 92% of children reported that they have 1 physical education activity per day. 50% of children reported that they have a weekly physical education class, 1 physical education class a week. And 54% of children report that they had a physical education class the week before the interview. What about school breakfasts? The 2012 National Survey of Food and Nutrition report that 86% of surveyed children had breakfast at home, and 8.6% of children in schools said had breakfast at school. 60% of children reported that breakfast at home was adequate or moderately adequate, and 94% of children that had breakfast at school, 75% of these children reported that they had already eaten breakfast at home. So, look at these school breakfasts and look at the nutrition components. We have cold, hot school breakfasts or morning snacks. We started all of these initiatives, but last year, of course, the pandemic started. If children go to school 4 or 5 hours a day, do they need to have a second breakfast and a snack, considering the fact that most children have already had breakfast at school? So we try to focus on the most vulnerable children that have no breakfast at home and implement strategies that include produce and fruits, local farmers purchasing from local produce. Of course, try to invite children in the preparation and consumption of hot meals. Obesity prevention needs to include schools, home, and community. And these initiatives need to be focused on children. And the two speakers before me mentioned this. Children are the focus of our activities. Look at these toxic environments in supermarkets in Mexico. Look at this. They give away gifts so that they buy 6 bottles of soft drinks. And apart from putting these figures of superheroes, and the children love to buy these superheroes with this superhero cow, children love to buy these snacks. So we need to focus on initiatives in and outside schools. Obesity prevention should be done early in life. Healthy eating settings, safe recreational activities, and physical education at school are essential. Legal framework for the regulation of ads of foods and beverages should be enforced all the time. Front labeling was a success, and we have this for food and beverages. Strengthen inspection measures. In Mexico, we have junk food taxes and sweetened beverage taxes to promote physical education, walking, and primary care initiatives, and improve care for obese children, changes in individual behavior, and change in purchasing behaviors to prevent obesity and overweight. So this should be a long life initiative from pregnancy of women in all stages at national level. We need to establish criteria about food and food preparation in schools. And we started this in 2012 with little implementation. We need to strengthen our initiatives, and we need to really see that facilities, I mean, there are no drinking water dispensers in schools, and we have to really regulate the sales of food and beverages according to nutritional criteria in all school communities. And parents need to really empower these changes. We need to foster committed participation of all policymakers, school councils, faculties, and make those responsible for implementation accountable for the inspection of these guidelines. Eliminate unhealthy food and beverages that are allowed on Fridays, and implement accountability mechanisms with penalties for non-compliance, and empower parents. We are currently implementing nutrition criteria for sale of products in school settings. I really felt so envious when I heard the two speakers before me, because there is no legislation in school environments. It's very difficult to work with authorities outside of schools. We need to implement a system to purchase produce locally for schools, and we're working on this. We need to standardize processes and create training manuals to monitor services and school with interesting training sessions for children on healthy cooking, with apps that the two previous speakers mentioned, and strengthen education curricula on healthy eating habits and physical activities. In our National Nutrition and Health Service, we try to monitor the appropriate weight of children, and of course, to make fresh water available free of charge with dispensers, with strategies to increase physical activity within schools and school settings. And of course, talk about healthy lifestyles in school curriculum. We in the academia talk about this, but we need to include this in schools. Classes have started in Mexico 1 month ago. So we're really focusing on revamping all of these initiatives. Thank you very much for your attention. And I'm looking forward to the debate.
Thank you, Dr. Teresa. A transição alimentar, ela tem acontecido.
It has been very specific in Mexico, the situation there, and the experience in the studies in Mexico, the lessons learned from them have been extremely valuable for the other Latin American countries. Thank you very much indeed for sharing with us. First of all, I wish to thank from the bottom of my heart on behalf of the organizing committee, your willingness to share with us today. Your availability been praised highly in the chat box, and I second them. But for us to take a full advantage of this final part of the session, we could now have rounds of sections, groups of questions.
We could have blocks of questions.
Mariana's picture has apparently frozen. Okay, something is wrong. It's Mariana's picture. Mariana, hello.
Mariana, it seems
Mariana?
We have lost you. We've lost you, Mariana.
We're all here.
Sorry, it was my connection. I'm back. Are you listening to me? Me desculpa. Bom, mas vamos
Sorry. Okay, let's continue with the question now. I would like for you to comment further on the challenges and lessons learned vis-a-vis the methodological and operational aspects of the studies that you presented here. In the same direction, if you could expound on the challenges that you met in the implementation and evaluation of the interventions, both the large and small scale ones. Finally, also related to that, how to conduct these intervention studies in the pandemic period and in the post-pandemic. And with regard to the digital food environment, we know that there have been many changes in the food environment during this period. So, well, who would like to begin? Feel free.
I could start and then maybe talk a little bit about some of the challenges faced in doing some of these small store or prepared food source carry out interventions. And then maybe Angela could follow up with something about doing multi-level interventions because they have their own set of challenges. So, you know, one of the big challenges in working with small food stores or carry out restaurants is the fact that their motivations differ greatly from public health, right? So our motivation is health and healthy lifestyles, healthy diets, physical activity, and so forth. And the motivation of most small store owners and carryout owners is profitability, making money, and public health is probably pretty far down their list of priorities. So so that's a big challenge. And one of the things that we need to do to address that challenge is find a way to make the work that we do, frankly, profitable and at least sustainable from the perspective of the small stores or the prepared food sources. And this means that you have to be quite selective in terms of, for example, choosing the foods that you want to ask stores to stock. You can't choose foods that are going to be healthy but unprofitable or money losing. You have to identify and promote those specific foods or recipes or whatever that are likely to be still remain profitability for the stores. Otherwise, they will not maintain it. Maybe that's all I will say right now, and then I'll let Angela talk, and then we can go back and forth.
Sure. I agree with Joel. I think a big challenge is to engage and recruit store owners to participate, or community members. We need to have strong relationship in these communities before implementing an intervention, especially a large scale. The project that I presented, it was a fruit of work from Dr. Gittelsohn for more than a decade, working in Baltimore first, and then we did this large intervention. So relationship is a key. And the same thing that happens with store owners is recruiting community centers or even schools to participate in the intervention. They have a set curriculum, and it's really hard to ask them to take additional time to include something else. The trust in the researchers sometimes is a barrier to getting people to participate in the intervention. I'm talking about the evaluation sample. Now, when we recruit families to be part of the evaluation, not everybody wants to be part of the study, especially follow through many years. And then there is additional challenge of finding people again. And when we work with low-income populations, it's even harder because they're more likely to move to another address, their phones get disconnected, they change their phone number. We really had to knock on many doors to get our sample follow up and be able to do the evaluation, the impact evaluation.
Puedo contribuir desde el punto de vista de México. Yo les quiero decir que
I can contribute from the perspective of Mexico. In Mexico, there are very many studies. I mean, there are more than 50, 70 studies at local level. What I show today has to do more with national policies and how things are changing in school settings. Yes, it is a challenge. I feel so envious of you because in 1 kilometer around my setting, I could even see how many Costco's or 7-Elevens or convenience stores there are. I can say that in 5 blocks, there are 7. And it's very difficult to bargain with them. There's no way because they belong to Coca-Cola. I mean, that's it. I mean, and it's very difficult to make any deals. It's very difficult. But so far, what we have learned is that we need to take one step at a time. And we don't do this alone. We do this with civil society and with other stakeholders. The government has to be our ally because without the government, there is no change. And when we started working on these guidelines, we made progress, but then there was another government administration. And so there was no permanence. So we need to have legislation so that we don't go back to square one when we change administrations. So we need to really make efforts and we implement things. And when we have a new administration, everything goes to square one. A very successful initiative in Mexico, and that you're probably familiarized, Angela does, I guess, is when we worked with Consumer Power, a civil organization, Poder del Consumidor, when we worked with them and we started implementing the tax on beverages, there was a lot of conflicts of interest. We had a lot of issues and problems, but what did we do? We started talking with population, with dissemination strategies targeted on the population. So you went to the streets, and in the billboards in the streets, you saw enormous billboards that said, would you give 7 spoons of sugar to your child? 7. No. So why do you give him such a beverage, for instance? And this was fantastic. Great repercussions. So, okay, one thing at a time. Then we started with labeling. That was a struggle. Now we have to keep on fighting for these labels because we have to raise awareness of the importance of labels. Okay, we have gone through stage one. We have the labels that are very recognizable. And we also had a lot of problems, but we're working together. Now we're working with the agriculture department in school. So one step at a time.
Thank you very much. Temos mais algumas perguntas nesse
We have a few more questions in this direction, but I believe that they've been partially answered already. So I'm going to read two more interesting questions, and then we're going to have another round of specific questions for each panel member. Okay, let's go. Okay, this one is in English.
Due to poor reporting quality of previous studies, you perhaps have assessed when designing yours. E gostaria que os palestrantes falassem pouco sobre o
I'd like for the speakers to talk about the community involvement in the implementation of the interventions, which Angela has already covered partially, at least, for us to complete this round, some specific question for each researcher. Okay, here we go. For Dr. Angela and Joel, the literature on food environments shows that the wealthy countries think supermarkets are a source of healthy foods, but this profile varies according to the context, as showed in Baltimore, and it was explored in the unhealthy profile of the small corner stores, for example. What is the view of researchers concerning this? What are the kinds of stores that public policies where they should encourage access to healthy foods in and focus on, considering this scenario that they've studied? In this same direction, and for the same researchers, what is the proportion to be adopted in the intervention studies that they performed for increasing the supply and purchase of healthy foods as a proportion compared to the unhealthy foods that exist locally? Does this depend on the kind of site, intervention site? And for Dr. Teresa, to what extent the reality of these public schools and private schools in Mexico are different between public and private schools with regard to the food environment and also the surroundings of the schools and the regulations concerned as presented from 2014. Do they also encompass private schools? How do the private schools react to this regulation in Mexico?
So this is a really interesting series of questions, which I'll start to answer, and then hopefully the other esteemed members of the panel can continue to address. So the first thing I'll say is you're absolutely right. Just because it's a supermarket doesn't mean it's a healthy store. In fact, supermarkets typically carry quite a wide range of foods, including a lot of healthy items and a lot of less healthy items. In fact, maybe a very high proportion of unhealthy items. So just putting a supermarket into a community does not by any means guarantee that all of a sudden dietary quality will improve, people will lose weight, there will be no chronic disease. That's absolutely not the case. And it's in fact something which has been studied in a series of naturalistic experiments where people have examined what happened when a new supermarket was put into a community, and they, much to their shock or disappointment, did not see much of a change in the healthiness of the foods being consumed. One thing that is happening in some settings is the formation of healthy food stores. Now, these are typically smaller independent grocery stores, but not a corner store. So it's a full-size supermarket, which has as part of their operational mission the provision of healthier foods to low-income disadvantaged communities. This is happening in a lot of places. I'm actually doing a case study piece of research on 6 of these stores around the United States right now, and I hope to have some conclusions about what they do or how they are, what makes them more or less successful. But one of the things that's really clear is that they have to have a very strong emphasis on community engagement, another theme that you mentioned. So by no means should you assume putting a supermarket into a community is going to all of a sudden improve the diets of everyone in that community. In fact, it may not be the best choice, because it's often very expensive and time consuming to put a supermarket into a community. Whereas if you work with existing food sources like small food stores that are already there, that are already open, that already have, you could actually, for the same amount of dollars or the same amount of investment, you potentially could have a greater effect in terms of increasing access to healthier foods. But of course, that's a debatable point. The other thing that you mentioned was about how much healthy to how much unhealthy food do you need to have in order to start seeing impacts? And I don't have a number for you, unfortunately, which says 90% healthy, 10% unhealthy, anything like that. I will say that most stores, even if they are dedicated to improving access to healthy foods as one of their missions, generally see the need to include some unhealthy foods because they feel they can't be profitable at all if they don't sell some foods that are and meets consumer demand at some level. In fact, there's been some very strong cases of stores that were pretty much all healthy stores that did not survive, that were not successful and couldn't be maintained. So these are really good questions. I don't know if we have strict answers for you, but I'll pass on to the rest of the panel members to carry on the discussion.
Yes, I can give a try. I think this is a great question. Supermarkets, grocery stores are not healthy food stores. As we know, they sell both ultra processed foods and produced. But the problem is, in many low-income communities, majority Black and communities of color, as I mentioned, people don't have access to grocery stores, and there is a disproportional availability of 7-Eleven, small corner stores. So they have just so easy for them to have access and availability to unhealthy foods, but very hard to find the fresh produce. There is no farmers market around them. There is no grocery store. And usually low-income populations, they don't have a car to drive to a grocery store. They rely on transportation. So going to all the way to a store and carrying bags in the bus and coming, it is a barrier. So I think just using what's available already in these low-income communities, those stores, and increasing the availability of healthy food, so low-income communities can have the same opportunities. That's the idea. We are giving them equal. We're trying. It's not equal at all yet. It's just a little step towards it. It's just we're trying to move towards equal opportunities for them to access healthy foods, because if you go to those communities, it's not equal at all. It's impossible. So in that, it's really correlated with the higher rates of chronic diseases that we see exactly in those same populations. So that's the idea. We don't have the magic number for how much we should improve of healthy and unhealthy. We need more healthy foods in these communities, and at the same time, give them the tools to, yes, it's there, and we give them the information, the social support. We change all the other levels to support healthy food purchasing and consumption.
Bueno, yo respondo.
Well, I will try to answer what I can contribute with. And the question for me was, what is the difference between private and public schools? I didn't say the following in my presentation. In Mexico, for school-age children, those that go to primary school, as we say in Mexico, from 5 to 12 years of age, elementary school, primary school, there are more than 200,000 schools in the school. Out of these, 12,000, 6% are private schools. So when we started with the guidelines for the sale and the distribution of food, and we assess, we do it in a sample of schools, of course, with private schools represented, of course, in the sample. But what we saw was that it was much easier to establish guideline in private schools, excuse me, due to the fact that in private schools, they don't have school breakfasts. Children arrives at school having had breakfast at home, and meal preparation is done with cooking techniques that have, due to the availability of produce in the neighborhood, more access to fruit and vegetables and less fried fruit. In public schools, this varies greatly. There are public schools in which there was a diner in which children can eat cooked meals. And there are schools, and I didn't show it, we have a very interesting study in which during breaks, moms, there are no canteens, mom open up a stall with a table with sugared beverages, with potatoes, with snacks, because there are no school canteens. So a mom, somebody opens up a stall. So we even found that in one school, there were 25 stalls selling these types of foods. So there's a difference between public and private schools, but guidelines are national. Implementation levels, monitoring, and follow-up are totally different.
Thank you. We're coming to the end of our roundtable. We're going to have a final round. Just one more specific question for each of you. So feel free to answer the specific question and for your final comments that you wish to make. The question for everyone concerns the sustainability.
But the goal is, with the limited funding we have right now, is to pilot the BUD app, to finish developing, to pilot the app, and then to expand and scale up to multiple cities. So it's kind of a stay tuned situation. Maybe next year you can bring me back for an update on what happened with BUD. Thank you.
I'd love to hear what BUD finds. So talking about sustainability, I just want to add to what Dr. Gittelsohn mentioned. As he said, there is a Baltimore Food Policy Director. So we worked a lot with policymakers in the city. That was another important component from the Be More Healthy Communities for Kids. And we involved them throughout the whole process of the intervention. The city is also taking over the Baltimore Healthy Corner Stores program, and they have their own staff going to corner stores and doing some taste tests, which Dr. Gittelsohn's team was also part of the evaluation of the city project. And with the after school program, I reached out to American Heart Association, who had a similar nutrition education with kids in like 1 or 2 other recreation centers, and we together revised their curriculum. They were able to include our nutrition education lessons that were evidence-based to continue to implement some of these nutrition education classes. And the idea was also, when we include community members in the implementation of the intervention, is that they will be community leaders and be advocates for healthy food change in their communities. So working with the youth leaders was also one of the plans, that they would be able to take over and continue and train younger kids and use the same method that train the trainer. That unfortunately did not happen because they're still high school students. They are off to college. They are competing they have competing interests, they're still depending on their parents. So there's still a lot that we can to think about, maybe work with younger ages, or even having a liaison in the recreation center or in the school to be the center and be able to train youth and young leaders to continue the program. I forgot the second question that you asked. Was it about changing unhealthy item? What, can you repeat, please? Sorry.
Yes, no problem. Bom, a pergunta foi, considerando uma possível mão de obra reduzida nas escolas e no after school, prepare a oferta de alimentos mais saudáveis. Pensando no alimento fresco, in natura, a necessidade da sua preparação e assim de ofertá-lo nas escolas.
Durante a pandemia.
Não especificaram, então fica à vontade para...
Okay, so in the United States, the foods are distributed. There is no local production. So that's the point. There is no chef or cook in each recreation center or each school. The foods are actually delivered to each school to minimize the staff, the personnel working with food. Well, I think the Brazilian model for lunch school meals is one of the best. So I would just leave that. I think having a cook and a chef in school preparing the foods and maybe involving teachers and students are able to smell the foods being made, and they just know the foods are fresh when they sit down to eat. It's very different than what kids in the United States think about their foods. They just see them coming, being prepared, just like quickly hit up, just put in the oven. But there's not a lot of fresh perception from the students, because it's decentralized. It's not a centralized production.
Bueno, y ahora yo miré muy breve por cuestiones ya del tiempo. Como lo mencioné en mi ponencia, la sostenibilidad tiene que ver con una palabra para nosotros, que es la institucionalización. ¿Qué depende para institucionalizarlo? Pues el legislativo, la academia, la sociedad civil, crear ciudadanía. Eso de crear ciudadanía tiene que ver con toda la concientización, el trabajo con los maestros, con los alumnos. Recordar que estamos hablando de salud, y la salud es lo más importante. Entonces, la sostenibilidad para nosotros de todas nuestras acciones es en el momento que se vuelve ley, que ya no hay manera y hay que sancionar a quien no cumple. Eso es lo primero. Y lo segundo es superar estas barreras para no tener tantos alimentos ultraprocesados. Hemos trabajado mucho y bueno, en la medida que la legislación va entrando, salen ahora sí que por todos lados ya los alimentos que son nocivos para la salud. Nos cuesta mucho trabajo todavía. Sin embargo, hemos tomado experiencias de otros países como Chile, en donde se puede llegar a los productores locales. En pequeñas escuelas hemos empezado a crear huertos escolares en donde los niños empiezan a producir alimentos y ya cuando lo ven crecer, ellos lo cocinan, entonces es algo de ellos. Son iniciativas que son muy pequeñas aún, pero sí estamos ya trabajando y estamos tratando de irnos a lo grande con ello. Muchas gracias.
Obrigada por abrilhantarem nosso evento. Muito bom ter os três aqui juntos, desde o início, convidados que foram tão gentis, tão engajados na preparação para estarem aqui conosco. E aproveito para convidar todos e todas para o lançamento do livro Ambiente Alimentar, Saúde e Nutrição, que acontece agora, em 5 minutinhos. Teremos sorteio de alguns livros e, na sequência, iniciaremos a nossa mesa 7, sobre avanços e entraves na agenda política da América Latina. Obrigada a todos e continuem conosco.
Hi, only to say bye. Thank you so much.
Bye. Thank you, Marcela.
Oh, it's
Gracias.
great.
Obrigada, Marcela. Foi
Gracias,
muito
Mariana.
bom.
You're welcome.
Great
Thank
to,
you.
Oh, it's great to listen to you. I love it. Great. I hope we can.
Thanks to the translators.
No, muchas gracias y por la paciencia.
Gittelsohn, did you learn Portuguese? Not, not yet.
No, not afraid not.
Claro, portuñol.
The discussion was very rich. I wish we had more time, but it was great. Thank you.
Good. All right. Well, we'll take care. Good luck with the